So what do we need? At the very least, we need broadly publicized best care practices. Okay. This is where patient advocacy can help. I don't have to invent the best practices. That's not my job. I don't have the expertise, I don't have the sheepskin, and I don't have the MD. And I don't do the clinical trials. That's not my gig. But when Mayo writes an article called Prognosis at Diagnosis, one of my favorite articles, probably the one article that I read early in my CLL career that has influenced me the most. And they lay out with all the weight and authority and prestige of the Mayo Clinic behind them that it is important to have a good, solid prognosis of the patient at the time that you're doing the diagnosis. So you get to see what the lay of the land is. I like that. Now, that's a best practice that is being proposed by a very credible institution, a very credible expert. And what can the patient advocacy group do? Well, we can take that article and we can run with it. We can write about it, we can explain it, we can turn the jargon into English so you can actually read it and understand it. And guess what? You can, if you ask me for the article, I'll send you the original article, not mine, the original, Mayo article. You can print it out, and the next time you go to see a local oncologist, make him a present of it. Okay? It may not do much for you, but maybe the next CLL patient who walks in will get a better oncologist because you have done the job of training him a little bit. There is confusion and there is danger in this lack of trickle down. Majority of patients and majority of doctors would agree that if you have a history of shingles, you've had it a couple of times, and you now have CLL, and if the doctor treats you with fludarabine as a slam dunk gold standard first line therapy, and you get an attack of shingles because you have not been given Valtrex to protect you against possible reactivation of this very, very insidious virus that most of us carry in our bodies, this is a tragedy. It's a tragedy certainly for the person who has it. One case history. All these guys put up their case histories, and I'll put up a few of mine. CLL patient, newly diagnosed, doctor never asked about his historical background of viral infections. Guy has had shingles before. He was put on fludarabine therapy within a month after the CLL diagnosis. Slam dunk, gold choice, right? He developed shingles in both eyes. He's now blind. Okay, the CLL is now a secondary issue. This man, a wage earner, mortgage payer, father, husband, is legally blind. Now, should this have happened? No, it should not have. This is a travesty. Best practices from Mayo and MD Anderson and most of the major institutions would say, if you are vulnerable for shingles, if you're treating the patient with T-cell depleting therapies, Campath, fludarabine, these patients should be on prophylactic Valtrex or similar drug, famciclovir, valciclovir, whatever. Now, Valtrex has been around a couple of decades. People have been on it for long-term usage to prevent genital herpes and things like that. So why the heck can our patients be on it when they're going through T-cell depleting therapies? Well, I see it as an inflammation backlog where stuff is not percolating. Experts know it. Local doctors don't know it. So what can we do? Short circuit the log jam. We find out about it. We ask the doctor about it. Looks like I've talked to my next slide, most of it. A couple of things that are on this slide that I would like to emphasize. How many of you, give me a show of hands, when you were diagnosed and your doctor warned you about the risks of skin cancer? A smattering over on that side, almost none over here. Back when I started, and we started almost a crusade about this, the percentage of patients, we did a rough study, percentage of patients who were warned about increased risk of skin cancer because of your CLL was less than 5%. And yet this is a major, major risk factor for CLL patients. You are immune compromised, which makes you much more likely that if you are pale skin and you like to hang out in the sun and you get basal cell carcinoma or squamous cell carcinoma, this is going to be much more aggressive in a CLL patient, especially if you've already been treated for your CLL. And you really need to watch out that the skin cancer doesn't become a second fight. Nobody wants to fight a two-fronted war, except America. We like to do these multiple war things. I'm an equal opportunity disser. I'll take a pot shot at anybody. So skin cancer, I've lost too many friends with CLL, with indolent CLL, who died of skin cancer. This can kill you. So there's a saying in India, only mad dogs and Englishmen go out into the noonday sun. I don't see too many Englishmen around here, so you got to be mad dogs if you're out in the sun. So take your pick. Transplants. We've heard about it all through this conference. The people treat them very gingerly, and they should. It's a tough call to make, and you make the call when you have nothing. In a sense, you have your life riding on this decision, no question. The transplant mortality is pretty significant. People do die from it, but the only procedure, and don't let anyone tell you otherwise, that has the word cure associated with it, is an allogeneic transplant, where we take out your busted, no good bum of an immune system and replace it with a healthy one from a willing donor. Lots of ducks to get in a row before you go for a transplant. The willing donor part is not trivial. If you are fortunate, if your parents had been productive in their youthful age and given you lots of brothers and sisters, you have a better chance of finding a good, what they call a sibling donor match. Somebody in your own brothers and sisters who will match you exactly on that HLA hand that they were talking about, and therefore a better chance of getting that transplant. If you don't have a brother or a sister that's a match, or you haven't been good about buying them Christmas presents and they tell you to go soak your head, you have no choice but to go look for a matched unrelated donor, which is all right if you are of Caucasian ancestry, and there are lots of Caucasians in the transplant registry donor banks. But if you are of ethnic minority, as PC was, I mean, there are not too many Malaysians of Indian origin in the donor registries, your chances of getting an unmatched donor are slim to none. And in PC's case, we did a worldwide search of every single donor bank in the world. There was not a single match. Man was unique, but this is carrying it a bit too far, I thought. So in his case, it had to be a latest new technology coming along called cord blood transplants, where they take cord blood collected from babies after they're born. This is material that is thrown out into the garbage bin after the baby is born. These cord bloods, this is the cord, umbilical cord. I really mean umbilical cord. And the blood inside it is precious, precious, life-giving stem cells that can be used to transplant. They have been used routinely in transplanting children till recently. Now they're transplanting more and more adults with these cord blood, and they're using what they call double cord, where they use two cords from two babies for one adult, because adults are big. You know, pediatric cancers, the recipient of the cord is a small baby, so a single cord is okay. But we are talking about a big guy, you're going to need more than one cord. So they're doing two cords.